time.
Excellent. So for the sake of time, we'll get started. Welcome, everybody. This is the February combined AAST PTS case series. I want to thank everybody for joining us today. My name is Dan Ricarte. For those that I haven't met before, I'm one of the acute care surgeons here at Hartford Hospital. And I will serve today as your moderator with Dr. Nemayas, who's pinch hitting today for us from the Pan American side of things. I would like to introduce our group of expert panelists today who have generously donated us their time to participate with us. I'll start with Dr. Paula Ferrata, Division Chief of Trauma and Acute Care Surgery at Inova and current President of the Pan American Trauma Society. Thank you again for joining us. Dr. Andrew Nicol, Head of Trauma at Groote Schuur Hospital in Cape Town, South Africa. Again, thank you so much for joining us. And Dr. Marcelo Ribeiro, Division Chair of Trauma, Critical Care, and Acute Care Surgery at Sheikh Shahood Medical Center in Abu Dhabi. Thank you again. I'll introduce the first presenter now. I guess we'll just start with Dr. Musa as his slides are up, if that works for both of our presenters. Dr. Musa is current Trauma Critical Care Fellow at Hamad General Hospital in Doha, Qatar. And with that said, I just want to let everybody know we're going to be presenting two cases for those that aren't familiar with the format. The moderators will be interrupting the presenters to ask questions of our panelists as the cases unfold. If you have any questions, please try to put them in the chat. I will try to keep an eye on that, and if time permits, we'll get to them. I will turn over the case now or the presentation to Dr. Musa. Thank you again.
Okay, thank you. So, hello everyone. I'm Dr. Musa. I'm a Trauma Critical Care Fellow in Hamad General Hospital. We are going to present today an interesting case about a recurrent oral bleeding after a blood trauma. Thanks to Dr. Musa Strandvik and Dr. Sandro for their help with the presentation. Starting the case, so no conflict of interest. Our patient is a 29 years old male with no past medical history who presented to our service on 14th of November at 4 a.m. He was a victim of an MVC, was unrestrained driver.
Can I just ask those that are not presenting or panelists to mute their microphones, please? Thank you.
Yeah, so we'll continue with the case. So he's a 29 years old male with no past medical history. Was a victim of MVC, unrestrained driver, presented to our service on 14th of November in early morning time. So the pre-hospital, the ambulance staff saw the patient on the scene. He was on the roadside and his car was next to him and actually it was gotten fire. The car was smashed to the commercial shop. The patient was alert, he was awake, however, he was not communicating and there was a large wound in his chin with an active bleeding. His vitals, BCS was 15, heart rate around 100, BP was stable. However, he was desaturating, so his saturation was 75% of room air. On supplemental oxygen with another breather mask, his saturation was picked up to 89. The patient then transferred to our hospital. He remained hemodynamically stable apart from desaturation, so his saturation was 72%. And there was a large laceration to the mandible with an active bleeding. So an immediate intervention done for the patient to protect his airway. He was shifted to CT.
So can I pause there for a second? I want to open, because I know Dr. Nicol has done a lot of interesting work, especially in South Africa with, this is obviously blunt trauma, but it looks like a combination of sort of penetrating trauma as well from whatever managed to lacerate his mandible. So Dr. Nichols, I'll start with you if you don't mind. Anything you guys would do sort of specifically in the trauma bay for these patients with sort of large lacerations near the oral or neck cavity that might be different to what, you know, some of us might do elsewhere?
Not really. I think to me it's fairly standard ATLS management at present. Obviously the patient needs to have an airway secured and to stop the bleeding. So I think everything's progressing as required from my side at the moment. I don't think I'll be doing anything differently.
Dr. Ferrata, any thoughts? How do you stop the bleeding of the neck or the chin? Like, it's a difficult area, obviously. You can't tourniquet this. You can't really do a lot of things. So thoughts on how to, while you're working the patient up, what do you guys typically do to try to control the bleeding?
Well, Dr. Countess, thank you so much for inviting us here and with this interesting case. So I think that it's not a secret that I'm one of the proponents to delay airway when possible. This is one of the patients where it's not advisable to delay the airway, right? Because the threat to life right now for him is the airway. I don't know how profusely he's bleeding, but you can see he all throughout, he has held his blood pressure. His SATs, however, are not holding steady. So I think for this particular patient, intubating is the thing to do 100%, like it was mentioned before. And then evaluate really how much you're really bleeding. Is this a pulse type bleeding? Is this a new thing? Can you find a hole to put a quick clot gas, a Foley catheter, something to hold pressure until you have a better diagnosis and a better plan of action. I don't know if anybody else in the panel will do something different.
Dr. Rivero, I think that the intubation part of it, I see some comments on the chat already talking about not intubating this patient. Is there an argument against intubating in your mind?
No, not at all, especially considering that the patient drops his saturation level between the pre-hospital and admission at the hospital. So we have to consider this patient have a dual combined mechanism of trauma. So it's called the padded dashboard syndrome, when you combine blunt trauma plus a penetrating trauma. So this patient is probably bleeding from the fracture side, plus we have to remember that we have the tongue inside the mouth, so there's other organs that can be effectively bleeding. So at this moment, I would secure the airway and then try to do the rest of the workup.
So
Right,
there's,
sorry.
There was I'm sorry to interrupt, but there was a comment in the chat saying, I would not intubate the patient in the ED, we should go straight to the OR. Well, I think it depends where you are, right? So if, I don't know how many people are here from Colombia, South America, but where I trained in medical school, we didn't have people that were experts in airway in the trauma bay. And so going to the OR, if you can, like just like don't even stop in the ER, just go to the OR in a place where it's safer. That might be the trick, but I was answering, if you are in a place where in your trauma bay you have people that are good at, this is going to be a difficult airway. There's no question about it, right? Because the blood is gonna prevent you from seeing well. In my experience, fiber optic does not work very well when you have bleeding. It's just impossible to actually see. So surprisingly, direct laryngoscopy actually works better for these patients than when you try to put a camera on. So I think it depends. Like if you're in the United States or in a place where you have all the resources in the trauma bay, then yes, patient needs the airway. If you are not, then you need to go to a place where you have all the bells and whistles to be able to take this patient. But either or, we shouldn't be waiting. I'm sorry for the interruption.
Oh, that's what we're here for, to hear the pearls of wisdom. I sincerely appreciate it. Dr. Musa, share with us, what do you guys do?
Exactly. So this patient was oozing from the laceration wound, and the bleeding was bleeding into the oral cavity, and he was intubated in the trauma room. So whenever we have an unstable vitals, we activate trauma code 1, and all the team will be available there, including the anesthetist team. So this patient was managed well in the trauma resuscitation unit, and after securing the airway, he was shifted to PAN CT.
And you control the bleeding how? I'm sorry?
Yeah, so the bleeding was like apply the packing on that area, on the oral cavity for him. And actually, it was controlled with the packing on that side. And later on, a suturing was done to the laceration, as we will see in the following slides.
Okay.
So the PAN CT was done for this patient. CT head was unremarkable, actually, with no acute intracranial pathology. However, CT neck showed that there is a C4 and a C5 vertebral body fracture. As we can see here, on the image on the left side, you can see the vertebral body fracture, which is comminuted fracture with like a linear line in the vertebral body as well. And on the right side, this is the sagittal view. The C5 appears more obvious about the comminuted fractures compared to the C4.
Correct me if I'm wrong, it does not appear to be a CTA unless I'm not seeing the contrast timing well.
Yeah, CT angio was unremarkable because right now I'm telling about the verbally I'm telling about the findings of the CTs. I'm just concentrating on the CT images about the important findings which will continue with us through the case. So in his CT facial bones, we can see that this patient was having a comminuted open mandibular fracture. We can see it on this image slides. And there is like a lot of cervical emphysema and swelling around the oral cavity, as it's obvious here. So this is the right side. You can see the direction of the trauma from the mandible and through the vertebral body of C4 and C5. Other pan-CT results, okay, for example, the CT chest was showing a two right-sided ribs fracture, sternal fracture, and lung contusions. And the CT of lumbar spine, he was having L1 fracture in the body. However, there is no canal stenosis. Now, the patient assessed by all the teams of maxillofacial team, ENT, and neurosurgeons. So when maxillofacial team assessed the patient, they found that there's an intraorally displaced comminuted symphysial and body fracture and multiple lacerations and missing posterior teeth for him. His wound was irrigated and was sutured, and after that the bleeding was well controlled actually, and they applied the wiring of the mandible for the fixation. Steroid and prophylactic antibiotics were started for him, and the plan was to start a clear fluid once he's extubated. From ENT team, they assessed the patient and they considered doing a nasopharyngeal laryngoscopy to assess his airway, possibly after extubation. Because of his fracture of C4 and C5, neurosurgeons proceeded with an MRI whole spine for him. And the MRI showed...
Can I pause you there for a second, Dr. Musa? Any role, Dr. Rivera, Dr. Ferrada, Dr. Nicol, anybody would do anything different in terms of going straight to the operating room, right? You've secured the airway, go to the operating room. Is there enough sort of physical evidence there that would sort of push you to go straight to the operating room?
Well, so I was going to comment that we have a protocol for these patients here in Innova, where if there's, I mean, this was a difficult airway when you intubate it. Now you have a C-spine injury and you have a wire jaw. Even if this patient was perfect and had no airway swelling, and if the pulmonary mechanics are great, you still have a chance of failing. And what happens when you fail an extubation with somebody that has a spine fracture and a wire mandible? Disaster, right? So these will be a person that here in this center will have a tracheostomy, elective tracheostomy, pretty early, because the chances of having issues and complication with the tracheostomy is less than the chances of dying from not having a secure airway with a C-spine fracture, mandible fracture, in a wire jaw.
Dr. Nicol?
Yeah, thanks. In South Africa, we take things a little bit slower. The rush to theatre I'm trying to work out is because it sounded like the bleeding was controlled with the packing. Because at this stage, I'm trying to work out why you had to rush him to theatre straight away. Because I'm very concerned about that C5 compression fracture. Is that a stable fracture? Is there some comment about the spinal team about the stability of that fracture and what their plan would be for further management of that? Have we got all the information we need before we move into theatre with this patient? You said that the lung contusions, there was another fracture. Was there anything in the abdomen or any other worrying injuries that we need to also consider?
Thank you, Andrew. So for his fractures, yeah, the neurosurgeons team planned for MRI spine to assess the fractures more and to see the stability. And actually, through the whole case, the plan for his fractures was continuing the conservative treatment So no surgical fixation was done to his fractures. And
Dr. Musa, with moving all extremities, and someone in the chat is asking why steroids?
yeah, to decrease the facial edema, actually. So in his case, like there was like a significant edema in his face and his area of the fractures. So before going for OR for fixation, they prefer to start steroids, deplete the edema for a couple of days, and after that, the area will be like will explode.
Dr. Ribeiro, thoughts on steroids for these patients? Would you administer? Would you hold off?
I probably would hold off. You know, I don't see like a very high evidence of using steroids for this specific purpose. So I probably wouldn't consider steroids at this point. And I would be also concerned about making sure the whole spine was kind of stable in order to move forward. But I agree that the surgical fixation of this fracture will be a need in order to try to control the bleeding in this patient specifically.
All right, Dr. Musa, please continue.
Yeah, sure. To clarify that his abdomen was clear from any trauma. So the MRI spine was done for him, and it showed the fracture of C4 and C5. There's like a little posterior displacement, C5 over C6, and a small epidural hematoma around 2.3 millimeters in thickness around that side, C5 and C6. So after that, the patient was transferred to our trauma intensive care unit. His GCS was empty, he was on sedation, he was moving all limbs, and was having stable vitals. His oxygen requirement was minimal, maintaining normal saturation. On day one of admission to our ICU, this patient was having kind of weakness in his hands and his elbows, but from a neurosurgery team, advised to continue the same conservative treatment on him, and he was kept on Sequoia. Maxillofacial team, on the other hand, they plan to do a definitive fixation for his mandible and to go for the ORIF in the coming days. Meanwhile, the patient was clinically stable with this STP. He was tolerating the SPT. Leak test was positive for him, and he was extubated on day 5. Now,
Dr. Nicol, I know Dr. Verada mentioned, I'm sorry, Dr. Musa, I just want to sort of hear Dr. Nicol's thoughts on the tracheostomy, right? It sounds like Dr. Verada and Inova are a little bit quicker on sort of tracheing these patients. Would you have sort of moved towards early tracheostomy, or would you have sort of followed what these guys did and ride it out for a little bit longer?
No, I think the early tracheostomy was a very good idea because it looked like a lot of swelling in the original CT. So I think that was a fair call.
Dr. Rivera, would you have trached him that same day that he came to you? Would you give him sort of a day or two to settle out and then do it?
Yeah, that's a really good question. That's a very interesting point of discussion because I personally think this patient would benefit for early tracheostomy, but I'm not sure. I probably wouldn't do it like right away in the first day, but I would really consider this to be like an early tracheostomy patient. So I would probably wait for 1 or 2 days, see how he goes, and then plan for that. I think it's very safe to get a tracheostomy for this patient.
Dr. Musa, please continue.
Sure. So this patient was extubated on day 5 of admission to ICU, and post-extubation, the patient developed a bleeding from the wiring side that was kept for mandibular fixation. At that point, a tranexamic acid was given for him, and F team consulted for assessment of his oral cavity. So upon their assessment, they found kind of edema and swelling in the oral cavity. The sutures were in place, and there is no hematoma or active bleeding in the oral cavity during their assessment. And there was like no change in the plan of management. However, they are still to ORIF for his mandible in the coming days. On day 6, the patient was having an increasing of blood secretions requiring frequent suctioning. So his DVT prophylaxis was kept on hold. Lab parameters for him were stable. His hemoglobin.
Is to you? What conference is it?
Yeah, and if anybody that's not talking could mute your microphone, please.
So we go for each.
Dr. Martos, if you don't mind just muting, thank you. All right.
Daniel.
Dr. Musa. Yes.
Yeah,
Daniel,
so-
I will need a couple of minutes because I have a bad trauma coming in the hospital. I'll go right downstairs and come back, okay?
Absolutely. Go ahead. Thank you.
Right.
yeah,
right,
so
Dr.
to continue with the case, yeah, his hemoglobin readings was 10.9, platelet of 278, INR 1.3, fibrogen was okay as well. His X-ray was clear, but what happened is that during that day, his oxygen requirement actually was increasing. So he was on high flow nasal cannula with FiO2 40, but during the day it was like increasing gradually 60% FiO2, and along with that 6 liters of simple mask.
Dr.
Day
Musa, I have a
7,
question. Oh, sorry. May I ask before we
yeah,
go
of
into
course, of
the
course. Yeah.
when I said there's a recorder before the tracheostomy, I probably did the tracheostomy not the same day, but early trach before 3 days. I also I'm unclear in my experience, DVT prophylaxis does not increase surgical bleeding. So I and giving somebody things to help them clot like TXA, without actually taking care of the surgical bleeding, I'm not sure is that much effective. But I do think trauma patients in general have a misunderstood coagulation cascade because they're bleeding, their body's trying to clot, and we're giving them things to help them clot. So holding DV2 prophylaxis, not stopping up in surgical bleeding, and then giving them TXA, I think is I think it puts you at higher risk of having any thromboembolic event. I didn't realize the patient went into PA-AAST until you had the other side, but that's just an observation.
Dr. Nickel, would you have stopped DVT prophylaxis or keep it going throughout all this?
Yeah, and I would have stopped. And yeah, I'd be very worried about these bloody secretions requiring suctioning. Yeah, it's just sounding like. I mean, unfortunately, I saw the title of the talk, but you know, CTA has that been done properly? Has there been any arterial damage identified on the CTA?
No, not at this time.
So
At this time, it's just oozing from the mandible fracture. Yeah, Dr. Rizoli here. Sorry to interrupt.
No, appreciate it. Dr. Musa, just, and again, I'm sorry if I just missed this, but the original CAT scan, did it include contrast? And what was the timing of the contrast? Was it intended to be a CTA of the neck?
yeah, so the initial CT, it was like a plan CT. However, CT angio was not done initially with the protocol. So CT angio will be done in our protocol if there is any like foramen canal fractures or involvement suspicious to the injury to the like an carotid artery or any major neck vessels. At that point, a CT angio will be included in the protocol. However, this patient CT without the feature the CT angiogram of the neck. It was
Dr.
done later
Pasquale
on
was
the
helping me
presentation.
pinch in here. Dr. Pasquale, thoughts on CTA? Would you have done it from the get-go on the trauma bay? Would you have just waited out and now that he's bleeding again, get it then? Your thoughts?
So I would say if you follow the EAST guidelines on indications for a CTA of the head and neck, C-spine injury, as this patient had, would put it right at high risk. I would have done a CTA up front. I thought it had been done, and in the absence of any evidence of bleeding on the original CTA, if there had been a lot of secretions that were bloody, as you describe in this slide, I would not have been worried, and I would not have stopped the sub-Q heparin in consideration of the fact that the spine fracture puts this patient at a high risk of DVT-PE. I think now you've told us, but the worry is if you have enough bleeding from these secretions that your hemoglobin is drifting down, or you have hemodynamic compromise, then I would have stopped the sub-Q heparin. So I'm not sure where you were landing on that day and how, at the end, how well justified it was to stop the prophylaxis in terms of heparin.
We only have 5 minutes, Dr. Musa, so I'm going to let you sort of progress through the case so you can get through most of your slides and give some final thoughts by our panelists.
Sure. So In day 7, the following day in the early morning, while the assigned staff nurse was talking to the patient and taking the blood samples from him, the patient actually deteriorated. At that point, directly, his heart rate became 30, he became desaturated around 60s, and he went into PAA cardiac arrest. And CPR was started according to LS protocol and continued for 5 cycles for him. And the patient was intubated straight forward. His intubation was easy. There's no active bleeding during the time of intubation. It was only like some kind of edema and redness in that area. So post-ROS, temperature was checked for the patient, the whole vitals checked, but his temperature was 39.4. And this is the first time to have a spike of fever. So a septic workup was sent for this patient, and he was started on broad spectrum antibiotic. Now, so the question right now about what are possible causes of his cardiac arrest, but I mean, if there is a possibility of time, we can allow for a small discussion. Otherwise, I will continue with this one.
Please continue. We're just going to be short of time like we always are. So, well, I'll try to hit the major points at the end.
Sure. So this is the chest X-ray post cardiac arrest. It's not that impressive. There's some like heaviness in the right and middle and lower lung zones. But it looks fine. The ECG is showing features of sinus tachy. There is no ischemic changes on this ECG or signs of like RV strain. A CT head, CT spine, cervical, and CT pulmonary angio was done for him. CT head was unremarkable. CT spine was showing the fractures of C4 and C5. However, because we thought about possibility of like loss of integration and destruction of the injuries, but there was no like destruction of the injuries and no significant retropulsion, no canal stenosis. CT pulmonary angio also done, and it was negative for a PE, showed bilateral extensive consolidations. So a few days, an MRI was done for him, and his MRI head was showing features of hypoxic ischemic encephalopathy, and his MRI spine showed some increase in the cord edema and contusions, but no other significant finding. Now, echo was done for him, no features of regional wall motion abnormality. His ejection fraction was 37. On day 8, his blood culture group like MRSA, Proteus, and Serratia, and sputum showed a multi-organism as well of MRSA, Proteus, and Pseudomonas. Since day 8 of ICU admission till day 11, was having persistent suctioning of a small amount of blood secretions, which was requiring frequent suctioning at that time. What happened on day 12 with this patient in the early morning, out of sudden he developed profuse massive oral bleeding from the oral cavity on day 12 after ICU admission. This patient was given 2 units of packed RBCs for negative and cross-match, but he was still profusely bleeding. So MTP was activated for him and oral cavity was packed. And this is the question right now, what team can do next for him. So our patient was taken, rushed to the OR, and he was kept on the hybrid room for the oral exploration, angiography, and a possible angiography, angioembolization. In OR, in the hybrid room, all the teams were there. Anesthesia team, maxillofacial, ENT, trauma ICU, and pulmonary GT. So ENT assist the patient. They found like an injury to epiglottis and to the lung base in the left side. It was like a small laceration. However, there was no signs of active bleeding or compromise of the airway. This patient, after having this profuse bleeding and transfused the blood and kept an oral packing, the bleeding settled. When ENT assessed the patient, there was no signs of active bleeding. Maxillofacial also assessed the patient. On their exploration, it was a negative for any source of bleeding from the oral cavity. So they applied an Eric arch bar and stabilized the fractures. And it was like partial assessment because this patient was already intubated with a large tube in his mouth. So it wasn't that complete assessment of the oral cavity. Then anesthesia and ICU trauma, they took over and they did a bronchoscopy. A bronchoscopy revealed an evidence of a clots in the pulmonary tree, which was such a large clots. It was sectioned from there, and it was showing an evidence also of some active bleeding of the lung. However, the source could be like from above the end of the endotracheal tube. So no laceration at about that area, but there is some elements of active bleeding, and this is what the confusing issue. So ENT assessed the patient.
Dr. Musa, just for the sake of time, if you don't mind, just fast forward to what we found, and then I'm gonna ask one final question to our panelists before we move forward to the next case.
Sure. Then this patient underwent the CT. The CT showed elements of a distal pseudoaneurysm arising from a small branch in the right facial artery. However, the segments of carotid and vertebral artery were well opacified and no elements of injuries or ablation. The pseudoaneurysm was occluded with multiple coils. And the image is showing these features of the pseudoaneurysm. The patient shifted back after the OR to ICU. He remained stable with no further attacks of bleeding. And on day 16, what happened? Maxillofacial team took him for the definitive fixation. They fixed the mandible, and after that, decided for the tracheostomy in the same operation. When they removed the tube to proceed with the tracheostomy, they found a large, deep 3 centimeters pharyngeal laceration, the midline position with an active oozing, which was repaired during the time. So there's like a multiple source of like an events happened to this patient, the multiple possibilities of his active oral bleeding, and the discussion was mainly about these points and the possible cause compared to the other. This is the timeline of the patients, as you can see here.
Dr. Musa, thank you. I want to use the last minute of your presentation so that we don't run too long to ask Dr. Nichols, Dr. Ferrada, and possibly Dr. Pasquale. In 30 seconds or so, based on everything that you just saw here, what would be your pearls sort of a wisdom, right, of dealing with these sorts of injuries? I'll start with you, Dr. Ferrada.
Well, number one, all that we're talking about is basically retrospectively. So this is not a criticism in your case. I'm happy that your patient is alive with this really complex injury. So congratulations on that. I think pearls of wisdom from my perspective, early airway, securing the airway early in people that have obstruction or difficult airways, early tracheostomy, with also going to the operating room and treating these issues as early as possible, because most of these patients, unless there's something else that is going on, we should be able to dispose them within a week, right? If we're talking about day number 16, there's things that could be done earlier, but at the same time, everybody has different resources. So I'm talking about what would happen in Innova. It's different in every place. And thank you for sharing with us.
Appreciate that, Dr. Nichols.
Yeah, interesting case. I just think that for me, the obvious thing is, if you pack the oral cavity because of bleeding, you've got to get an adequate CTA. I don't know, that might have just changed the course of this case. I'm not sure, but you've got to exclude and find that source of bleeding.
All right, I appreciate that. We're going to conclude the first case here and move on to the second case. I want to introduce our second presenter, Dr. Joshua Shinkowski. He is a current critical care fellow at Metro Health Medical Center in Cleveland, Ohio. I also want to thank his mentor, Dr. Kaylin Ritter, who is present here with us today. I'll turn the case over to you, Dr. Shinkowski.
Hi, everyone. Thanks for having us present our case here. I'm presenting here from Cleveland, Ohio, and with my attending, Dr. Ritter, who I think is here with us. Our case starts with one of our trauma activation pages. So we get paged out for a category 1 trauma. It's coming in about 5 minutes. We have a 15-year-old male with a GSW to the torso. And EMS is reporting that their systolic is in the 60s. the patient arrives to the trauma bay. They're hooked up to the monitors and immediately seem to be tachycardic or hypotensive. We have systolics varying anywhere from the 40s to the 60s. They're diaphoretic. Here, for our penetrating trauma patients, we try and practice an early exposure. So we go ahead and expose the patient completely, find all the holes. He has one GSW to the subxiphoid region and another one to the right flank. His airway's patent, he's breathing well, breath sounds are heard bilaterally. He's tachycardic, hypotensive, all his pulses are intact in his extremities. He's GCS 15 and his pupils are reactive. However, he is in distress, he's anxious. He's a little bit on the confused side, but is there with us. We get access established, bilateral 16 gauges. We start immediate blood transfusion from our blood bay or from our blood footage in the bay, activate our MTP protocol, and then notify that we're coming, notify the OR that we're coming. So actually, I put this time up here because I'm actually just really proud of it. We spent only 8 minutes from the time that the patient rolled in to our trauma bay until they rolled into the operating room. And that's like a 90-second trip. So most of that, so I was actually really proud of this. I will say it felt like forever though. So I was really surprised when I actually saw that number.
I can't imagine that anybody could do it any quicker than that, but I do want to get Dr. Ferrara and Dr. Nichols' thoughts on direct to the operating room. Anybody doing it? Thoughts on
100%.
moving to that?
Sorry, Dr. Ricaute, I didn't mean to interrupt you, but I'm really excited that so many centers are practicing this way, and we have been practicing this way for a while. This is exactly the patient where circulation, airway breathing is better than airway breathing circulation. When you have, even if the Glasgow Coma scale was less than 8, when you have penetrating injury and people that are bleeding to death, they're not perfusing their brain, they're going to have a low Glasgow. And stopping and doing and intubating somebody so you can cause vasodilation, decrease venous return from positive pressure ventilation is a for sure way to kill somebody. So I think that this was, I'm really proud of you for being 8 minutes, and I know that a lot of high volume centers already practice this way. This particular patient is where circulation first actually helps them. Hemodynamic and resuscitation, and go to the OR and then be ready to stop fast, because the moment that you intubate, this patient is going to code.
Dr. Nickel, do you agree?
Yeah, I had to be the stickler with a slightly different attitude. Yeah, this is just too quick for me. I think I'd have a heart attack if someone got into the theater that fast. I'm still trying to work out what the issues and the problems here are. Like, does he have a gunshot to his heart? I mean, what cavity are you thinking of opening up? Are you opening up his chest or his abdomen? Where's the bleeding coming from? You know, and I understand this move, and it sounds very exciting to head into theater, but you know, what exactly are we operating on?
Dr. Pasquale, I want to gather your thoughts on this. Are you in the middle here?
No, I don't. I think I agree with the transition. I thought your question, Dr. Ricarte, was whether to transfer this patient directly to the operating room.
Yeah, that's partly true. Yeah, absolutely.
Yeah. So I think if you have that capability and you can resuscitate in the OR, going straight from helicopter to OR, for example, would be an option. We can't do that at Penn, so it would be on the clock with a short trauma bay time, as Dr. Ferrara said. The only thing I would have done before flying to the operating room would have been a chest x-ray, because I think if there's a tension physiology here, that's potentially something that needs to be addressed before heading into the elevator or there, and potentially do at least a needle decompression. But otherwise, I would agree with a hurried presence under 10 minutes maximum to the operating room.
The other thing that I was quickly going to mention is, like, some places in the United States have the x-ray that goes immediately and you don't have to move the patient. But if you know how to use an ultrasound, you can quickly say pneumo, no pneumo, hemo. Is there fluid around the chest? And you don't need any. And then if you're there, sees fluid in the belly. To the question that was of Dr. Nico before, why are you going to operate it on? You're going to open whichever cavity has more blood. And you don't need. This is the situation in my experience where you intervene before you diagnose. Your diagnosis will be in the intervention that you do to save a life.
Dr. Strandvik, tell us what you guys did.
Yeah, so
Can I
in
make
all
a
fairness, I
comment?
probably should have put it up on the slide. Oh,
Yeah,
we
can I make a
did do
comment?
an ultrasound, by the way. So, yeah.
Can I make a comment?
Yeah, quick comment, please.
Yeah, this is Albert Barron from Ryder. I agree. The sooner the patient can be in the OR, the better. However, going straight from the helipad to the OR, it's a disaster. We have tried that. We have tried straight from the lobby to the OR. It's a disaster. Unless you don't have computerized systems. Try to get anything from the OR with the patient without a hospital number and a tap and cross. It's a recipe for death. So I think you need to stop for a moment just to get the very basic. 8 minutes sounds good. The sooner the better. But if you try to go straight, and we have done that, we have that in video. Patient was dragged from the lobby into the OR bay. It's a disaster. It's a total disaster. Don't think that the OR is going to have everything open and ready, and you're going to have a hospital number so you can open the chart, that you can't do a thing. Now, the ED people or the resource people have this down to a happy meal. So they know exactly what they need to do. They're used to do that. Now, if you decide that you're going to do this in the OR, since this is not going to be a common event, you really have to practice and simulate and do all of that before you do your first patient. Otherwise, it will be really bad. That's my 2 cents.
Appreciate it, Dr. Aaron. All right, Dr. Strandvik, what did we do here?
Yeah, so I will say we did ultrasound the patient in the bay or whatever. Nothing in the chest. There was fluid in the belly. So we're going to go in the belly. We started with a laparotomy, large volume hemoperitoneum. We evacuated the blood and packed the quadrants. First thing that we saw in our face was an anterior liver injury that was actively bleeding, and then some bleeding from the region of the portal triad. We put a Pringle on and then packed the liver tightly. Still had quite a bit of bleeding from behind the portal triad, and a large zone 1 and expanding zone 2 hematoma on the right.
Dr. Strandvik, can I just stop you here? Because I think this is obviously, we're going towards a rabbit hole that we all trauma surgeons hate, right? Which is that bleeding behind the liver that doesn't want to stop with anything you do. I do want to gather our panelists' thoughts as to what comes through your mind when you're doing this, right? You've Pringled, you're still bleeding, right? What are your thoughts, alternatives, right? In the operating room, and some pearls of wisdom for especially our trainees on the call as to, what to think of. Dr. Farad, I'll start with you.
Well, so you already, the slide is giving it away, right? You had an IVC injury. It's like 6 in the slide. Yeah, so for anybody that is listening to this, that is a trainee, you go through the phases. So 90% of the liver bleeding is gonna get better with packing. You pack, and you don't just pack, you just sandwich the liver. And if it doesn't work, you have to start looking, is these right red portal, or if this is venous, right? If you have big blue, I think you repair when you can, you ligate if you can't. I think that for all of us that you're in training, you should all try to do the atom course, because the first time that I had an IVC injury, I repaired 8 IVC injuries in pigs. And it was so much, the brain and the hands are trained differently, and you don't have to go yourself into SVT when you see that much of bleeding in the belly and you have never seen that before, or you only have seen that in a book rather than in a live situation. I think those injuries, the cardiac injury and the IVC injury, are the things that the atom course is the best at. What else? Somebody else, I guess.
Let me ask Dr. Nickel his thoughts on this, how to prepare yourself mentally and physically for the torrential bleed that's coming your way.
Yeah, well, I think, so I mean, I'm just glad. So now we've got the fast. So now we know that there's no cardiac problem, because I was trying to say, like, which cavity are you going to go into? Because that for me was the issue. And then dealing with the liver now, I think, I mean, you've got a cross clamp on the aorta, is it? Looks, I did see that somewhere. It's an intermittent cross clamp.
Not yet.
Obviously,
yes.
Yeah. Visceral medial rotation is, I mean, but there's a hole in the portal vein as well. I mean, this is a hell of a case, isn't it? I mean, it's not just the suprarenal IVC, it's portal vein as well. Wow. Okay, and then you did a right nephrectomy.
So if it makes it easier, Dr. Gaski, why don't you tell us what we found, right? Because I try to interrupt it, but I know people unfortunately are able to read the full slide, right, and kind of gave it away a little bit. So let's see what you found, and then we'll sort of circle back and see what some of alternatives were and how some of our panelists would have tackled this maybe differently or the same.
Yeah, sounds good. So after we completed that right medial visceral rotation, we saw that there was this laceration in the suprarenal IVC. So fortunately, not behind the liver so much. We definitely could see it. We at this point, after kind of getting into that hematoma, kind of had pretty significant hemodynamic compromise, and the patient was pretty much peri-arrest. And so me and another one of the trauma attendings opened up the left chest and got some aortic control in the chest. At the same time, we repaired the IVC laceration with pelagiated suture. We were able to take down that Pringle, and we had a pretty significant through and through injury to the portal vein. So we also repaired both that anterior and posterior side of the portal vein. That zone 2 hematoma was explored. There was a destructive injury to the superior pole of the cava or the kidney, and then another caval injury right at that confluence of the IVC and the right portal vein. So we performed a nephrectomy and then repaired the IVC again at that level. We packed the abdomen and then temporarily closed the abdomen and chest with vacuum closure.
All right, let me pause
10
you there for a
liters.
second. There's a lot to unfold here and unpack here. No pun intended. Dr. Pasquale from Penn, obviously, I know in the comments section in the chat, people have thrown out the idea of getting control via Reboa. Thoughts on using a Reboa?
Yeah, I think once you're in the belly, though, I would have tried to get to aortic control either infradiaphragmatically or elsewhere. But I guess if that was not possible, maybe because of hematoma, then the left chest a thoracotomy would be the approach, or a Reboa. I think we would have probably done a Reboa by just to avoid opening the chest, but I think it's viable too. Otherwise, I think the approach was good, and the portal vein can be repaired subsequently with initial clamping of the porta hepatis. The Reboa and the left chest, foregoing the left chest thoracotomy might have been my approach.
Dr. Nick, any thoughts on atriocaval shunts for this sort of injury, your use on them, and how successful are they?
More authors than cases of survival.
I agree. The one thing that I was gonna caveat for everybody is like, if the Reboa needs to be placed not from the abdomen. I tried that, and I successfully was able to put it in the iliac, but I'm telling you, it's not easy because of the angle. So it's very easy to create a false lumen, and you actually have to grab the artery and put it in your face to be able to pass it through. I'm never gonna try that again. So just FYI, if you're gonna put a Reboa, then you have to plan, and you have to put your A line in the common femoral artery, I would never try it again to pull it from the iliac in an open abdomen, but I tried it. The angle is terrible. Just FYI.
You put
Dr.
the Reboa.
Sorry, Dr. Pasquale, go ahead.
No, I was just wondering, are you saying that you tried to put the Reboa from within the abdomen?
I did, and I did
I
actually, and I did place it, but it was longer. It took me longer than it should have, and it's not a thing that I'm gonna do it ever again.
That's a great pearl, though. I can't think of many people that have at least, published that. So it's an interesting thought for sure. Dr. Nick, thoughts on the case and what you would have done in terms of managing this sort of injury?
Yeah, I'd just love to know kind of, I mean, he sounds like he's like hit the edge of his physiological envelope, hasn't he? He's really in dire straits. And I must say, opening up the left chest takes me a long time to do. So I like that supraceliac, the cross clamp of the aorta in through the abdomen. I find that very quick, and you just push the esophagus to the left-hand side and put a clamp onto the aorta. That to me is far quicker than opening up a chest and trying to get a cross clamp on the thoracic aorta.
Does that affect your exposure at all? Right now, you have a cross clamp sort of in your way there. Does that affect your exposure at all?
No, not at all. And in fact, you don't often have to apply a full clamp. You can actually get something that we call the aortic compressor, which is an instrument with a V, and we just push down onto the aorta. The assistant does that. And it allows very, very quick, and certainly some improvement in his hemodynamics. I'd just like some comment, just also just about how, how long is this all taking? Because we're obviously in damage control mode. How long was the operation? How long did this take?
Dr. Jankowski, another 8 minutes to get control, or what was the timing?
This was this one was a little longer. I can't, off the top of my head, I can't give you the exact time. I think it was around 2 hours that we were in the OR, somewhere there.
Okay. Yeah, it's just, for me, it's always a difficult one because we're trying to limit the amount of time we spend, isn't it? And I kind of think, we're repairing the portal vein, and a lot of people say we should do that, but certainly there have been survivors with ligation. I don't know how difficult the injury was and how much time was required to repair that. I agree with the right nephrectomy. I think that should have come after there was an issue and the patient was bleeding from that. But so just really for me, a question of how we decrease our time, and that's kind of like why I try and avoid opening up the chest if I can in these patients, just to try and decrease our operative time.
Any role, Dr. Pasquale, Dr. Ferrata, on shunting any of these injuries to try to get in and out as quickly as possible?
Go ahead.
Well, I don't, I have put one, I have put one shunt, like short trunk shunt in a human, and it didn't work. The person didn't survive. I have done it in pigs a ton. I think in terms of repairing the IVC does not take long. Repairing the porta also does not take long, depending on how you do it. I commend you for putting pledgets. I don't think I have put pledgets once in an IVC repair, but that I don't know how much you save time with this. Overall, is I don't know how long did it take you, but I also think that you cannot leave the OR. We're doing damage control, and I assume your anesthesia colleagues are resuscitating 1-to-1-to-1, but you cannot leave the OR without taking care of surgical bleeding. So it's a conundrum, right? You have to be there until you control bleeding, you resuscitate appropriately 1-to-1-to-1, you make sure your patient doesn't get cold. You're obviously going to leave this patient open. Everest, and this is a very place thing to use Everest, because I know in places with low income it's not there, but it's really nice. Like if you suture the IVC and you see that it's oozing a little bit, instead of redoing it with pledges, just put a little bit of Everest on it, and it's like magic. I don't know, Dr. Pasquale.
Yeah, I'm not sure why you decided to use pledgets on the cava. I guess it might have been a very ragged injury. Is that why? And then my worry is, did you narrow it by putting the pledgets in there in a mattress type fashion? I haven't done that either before. And then the other thing is what Dr. Ricardo was suggesting is maybe to cut down the time. I'm also worried, as Dr. Nichols, on taking too long here. Could a shunt have been placed in a portal vein for later repair or not? That's the only other things I would suggest.
Dr. Jankowski, we have 6 minutes left of the case, so any thoughts, and then I'll conclude with our panelists with some of the sort of pearls of wisdom for this sort of injury.
Yeah, so I think that the pledgeted was kind of just the attending's kind of practice on the repair. I think for as far as like the shunting goes, I think it's really hard, like you had said, to leave the operating room with actual surgical bleeding. And the two in the portal vein were relatively like clean punctures, front and back. I think they took, a suture or two each. I think almost shunting and repairing, I think in terms of time would have been about the same. And I think in terms of time in the operating room, I agree, it would have been really nice to shorten it. But I think all the injuries that we did end up fixing, I think would have been really hard to manage somewhere else outside the operating room. Yeah.
Dr. Nicol, someone in the chat mentioned splitting the diaphragm to get supraceliac control. Thoughts on that? Do you think it's necessary? Is it doable?
Yeah, very, very, very doable. With a little hockey stick incision through the diaphragm. It's been well described, and I've done it on a couple of occasions, and it's fairly simple to do. It's a very quick way of getting total hepatic isolation if you do require it. But I don't think it would have helped that much in this particular case. Is it super? Yeah, not sure. It sounds like you got adequate exposure and were able to repair the injuries. Yeah, I must say I'm still quite a fan of ligation of IVCs because it's quicker. And I know there's been a couple of papers saying that the outcomes are worse, but I think it's the IVC ligations are done in the sicker patients, and but to me it's a quicker procedure to do, and with fairly minimal morbidity of the patient survives.
Does ligation of the IVC matter if it's supra or infrarenal or infra and infrahepatic? Does that matter, or is it all the same?
Yeah, well, obviously, because this is the right kidney, if I remember, so you've got the left kidney, you do have those collaterals coming from the left renal vein, so you can ligate the suprarenal. Obviously, it's not ideal, and it's it depends on the extent of the injury and the physiological status of the patient. But I just had this feeling, through my career that we've been operating on these patients for too long, and we say we're doing damage control, but we're not. Yes, we're stopping bleeding, but we're not really doing damage control, are we? The procedures are just taking too long, and too many patients are dying on the table.
Dr. Ferretta, any thoughts on once you repair the cava, right? Because you tend to narrow it quite a bit, right? Of possibly stenting it down the road?
No, I think that I have repaired when I can. I have ligated when I can't. I agree with the comment of Dr. Nicol that the data that we have to make decisions about these injuries is not great data. It's all retrospective, and patients that get IVC ligated are sicker, and that's why they do worse. I think you do what you can. And I think if you're a patient after all of this is alive, congratulations, more power to you. I do agree we need to decrease the time that we're in the OR. Repairing a cava it shouldn't take that long. You pinch it with your hands and that slows up bleeding. You put the first Satinsky, which is never right. So then you put another one, and then you go back and forth, or you do the Alice's. And then they get narrow, but this is a narrow with time is fine. I have not had a person having a PE or massive issues with leg swelling with an IVC injury ligated or repair, but maybe I'm just lucky. I have seen them with iliac vein injuries, ligations, and but not with IVCs. But it's just my experience. I think congratulations in a great case. And yeah, thank you for including me.
Dr. Shinkowski, any other slides so we don't miss any of the major points on the case, and then we'll have a final minute for our panelists.
Yeah, I mean, he came back to the operating room about 8 hours after the index operation, once he was physiologically a little bit better, and he was still bleeding a little bit. Got some more resuscitation. At that point, he had like a dead gallbladder, and so that was taken out. And then at the third operation, he was found to have like some decerosalization of the kind of like mid hepatic duct and a mucosal defect there. So that was repaired. Wasn't a super high quality repair, so did end up needing an ERCP and a stent placement. So you can see kind of on there a little narrowing of that hepatic duct just before the bifurcation. He actually did pretty well, ended up with an episode of cholangitis from a stent occlusion. So that kind of prolonged his time in the hospital, got some bacteremia. But he ended up being discharged home on post-op day 26. He had his ERCP about 5 weeks after hospital discharge, a repeat to get the stent out, followed up in trauma clinic, was doing really well. Actually, I was looking at his chart to prepare for this, and he had his 16th birthday 2 days ago. So he's doing fantastic.
Amazing work. All right. And just to be respectful of everybody's time, I'm going to give our panelists 30 seconds for your pearls of wisdom in this particular sort of case. Dr. Pasquale, I'll start with you.
Oh, I thought it was a very good approach to the pediatric patient with a very worrisome trajectory. I think using Reboa judiciously versus clamping the aorta versus opening the left chest, depending on your resources, was really good, packing as needed, and then Pringle maneuver and other portohepatus maneuvers. I think I would be worried about an arterial injury as well so hopefully there was a CTA done around the road and maybe evaluation for pseudoaneurysms within the liver, but otherwise kudos.
Dr. Nickel?
Yeah, Dr. Sinkowski, I think it's absolutely fantastic that you got this young boy through with a portal vein injury. I mean, I know how difficult they are. I think that's phenomenal work, and congratulations. I don't have any pulls for you. I think that's absolutely marvelous.
Dr. Ferrata?
I agree with all the comments made. The only comment is like, it's great. We do this great job in saving these patients from death, from these terrible injuries. And we need to make sure that this person is not in this situation again. 15 years old already with a gunshot. So we all need to do a good job at trying to prevent these injuries, because the highest chance of this person having another injury is having a previous penetrating injury.
All right, it's 1:01 here Eastern time, so I want to wrap it up. Say thank you to everybody. Special thank you to Drs. Ferrata, Nickel, Dr. Ribeiro, and Dr. Pasquale for being our expert panelists today, and Dr. Sinkowski and Dr. Musa for their presentations. And we invite you guys to join us again next month for this AAST Pan American Trauma Society case series. Thank you again all. Really appreciate it.